Bismillah ar-Rahman ar-Rahim. In the name of Allah, the most gracious, the most merciful. وَأَمَّا بِنِعْمَةِ رَبِّكَ فَحَدِّثْ. As for the favor of your Lord, report His gifts to you. Welcome everyone. My name is Asma Shaboon. I'm one of the pediatric doctors currently working in the UK. And this video is about the MRCPCH clinical exam. I'm going to cover the value of the MRCPCH on whole, and then we're going to focus on the clinical exam, what is it about, and some success strategy and my own technique of study, and I will share my notes with you. So the value of the MRCPCH is that it's a way for you to get the GMC license as an alternative to the PLAB pathway. It's a requirement in your UKA training. The current rules is that you have to finish all the written exams by the end of the ST3 year and the clinical by the end of ST4. In some countries, it's a very respectable and honored degree in the field of pediatrics, so a lot of people do it. The MRCPCH itself is 3 written exams and 1 clinical. So the first part is the written, which is the foundation of practice, the theory and science, the applied knowledge and practice, and the clinical. So in abbreviation, it's the FOBAN, TOS, AKB, and the clinical. You can do the clinical, the written ones in any order you would like to, but to go actually for the clinical exam, you need to pass all the written before you go for it. Timeline for the MRCPCH clinical and the written is depending on every person, but I would say on average it takes a year. But because of the booking for the exam and finding a slot and preparing for things, the more realistic timeline would be from 1.5 years up to even sometimes 2 years, based on the availability of the seats. But for study-wise, how long should it take as a study away from finding the slot? I would say the FOB and TAS usually take 3 to 4 months. The AKB take 2 to 3 months, and the clinical should take 2 to 3 months. Some people do prepare in less, so it depends on your circumstance. But I would say that if you really want to pass from the first time you enter for the clinical, give it proper time. So 2 months is pretty good. 1.5 months is also acceptable, but less than that, you're going risking the fact that you might pass from the first time. Logistics of the exam. So the cost depends on which center you're going to take the exam in. So it ranges from £833, sterling pounds, of course, up to 1,605. So I mean, these are the current prices, and this is now April 2023. So you have to keep checking the website for the updated price, and depending on the country you will take the course in, the exam in, the cost will differ. Usually the exam happens 3 times a year, and they call them the diet courses. And on the diet, it depends on the center, but you will find many centers in the UK. You will find also few centers on the Middle East and different countries as highlighted. Also in Asia, there are also multiple countries there. The format of the exam is currently a face-to-face with patients on it. In the last few years, it has been without patients because of the COVID pandemic. But now, just from this February, we are back face-to-face with patients in all stations. Some countries still doesn't have a patient on the development like the UK, and this might change in the future. The total number of the stations is 10 stations. The requirements to apply, as I mentioned, you have to pass all the written, and usually apply online, and you need your supervisor to sign up for you that you are ready to take the exam. Be ready that usually all the places for the exam get booked very fast, so you have to be ready for it. And if you get accepted, then you will pay. So you don't pay from the first time you apply, and then they will hold you a seat until they review your application. And then if they accepted your application, then you will pay for it, and they will give you a link afterwards. So what is the experience of the exam? It's a 1-day exam. Usually the exam itself is 2.5 hours. And usually it runs on the morning and an afternoon session. However, the whole experience takes almost 4 hours because you have to attend to the center 1 hour early to get into the registration and to fill your mark sheets with your name and your details. and also to get a little bit of center navigation. So they will show you how the exam will run through the day and where are the stations and the services and the toilets and everything like that. So what should you bring with you to the exam? You have to bring your ID. It has to be a passport or a driving license. And then you have to bring pencils and not pens, because the only thing that you can use on the mark sheets that can be recognized in the mark, like on the coding programs, is the pencils. So bring pencils with you. Like with the things that you can take to the station with you is the pencils, of course, the stethoscope, and you can bring your own torch. Yeah. For the day, you have to dress smart. Think about a usual clinic day. So dress comfortable, and when you are there, make sure you have your sleeves up because you have to be bare below elbow because you have to really adhere with infection control guidelines. Currently, we still have to wear the face masks on the exams, at least mainly on the clinical ones. Every center has its own rules, but for the center that I went in last February, you can actually remove the mask on all of the station except the clinical. I think this is important because the communication scenarios and the history taking and so on, it's good that the patient will see your face because of the communication and the facial expression really convey a lot. So the number of stations, as I said, they are 10, and it's an OSCE style exam. There is no breaks on the exam, so you have to be ready for it. And usually the exam runs faster than you think. This is a website that I'm gonna rapidly open for you guys. This website is from the RCBCH website, and it's about the clinical exam. How can you apply all the centers, all the dates? So go for it to know about the dates and the times and everything, and check it out, okay? Because they get updated all the time. And as I mentioned, the cost differs based on the center, as you can see. So next, so you told us about the 10 stations. So what are the stations made of? So this is a very important sheet because it will give you an overall highlight. These are the 10 stations as you can see here. So you will have 4 short clinical stations where you will have the patients on them. They are all children, and you need to conduct a clinical exam and then have a short discussion with the examiner. Then you will have 2 long stations, and we call them long because they take long time of the exam. So all those lovely small stations away from these 2 long, every one of them is 9 minutes in total. So every station is 9 minutes. But the 2 long station, they are 22 minutes long. Okay, and that's why we call them the long station. And you can see down here on the marks, like the total marks for every station, the long station are having higher marks than the others. So most of the short stations, which is 9 minutes a station, will be 8 marks each, except the video stations, which will be only 6 and 6. So in total, you will have 4 short stations, 2 long stations. One is a development station, the other is the history station, and then you'll have 2 communication station and 2 video station. These are the marks for each station as mentioned below. So 8 marks for every short station, except video, each is 6. And then for the long stations, you'll have 12 for the development one and 10 for the history station. These are the domains you will be marked against. So the examiners in all of these stations will be trying to mark you against specific criteria, and those depend on the dimension and the aspect of the station. So for example, on the clinical station, you are not taking any history or sharing with the patient any information, so you are not gonna have any marks on those, but you will be marked on physical exam, identification of your signs, interpreting those signs and making clinical reasoning of what you're going to do, and then the planning, the management planning wise. In the development, you will do all of that, but also you will take a history from the role player or the mother of the child, and then you will communicate with her. So these 2 things will be assessed. In the history station, you don't do any exams, so you are not going to be marked against it, but you will take history and you will have some communication with the role player and sharing with the examiner your management planning and clinical reasoning. So you'll be marked against it. In the communication station, for example, you will be sharing information with the patient. You're going to communicate with with the patient or the child or the carer or the parent. So you will be marked against your communication style, your listening style, and if you manage the concerns of the patients or not. In the video, you have no patients on the room, but you'll have a video clip which you have to identify the clinical findings, and then make a clinical reasoning and interpret what does these signs mean, and then what's the plan. The total marks for the whole exam is 82. Okay, as we mentioned, this is the category, and there is a specific success criteria and strategy that you need to build in mind to pass on this exam. We're going to talk about that later. How does it look? When you go to the center, they will introduce you to the center, and then they will give you your paper sheets, and they will give you your own circuit. The circuit means that every one of you guys, you'll be 10 doctors, and then you will be divided into two teams, and everyone will be standing in front of one of those stations. So every one of you will be standing in front of those. So one of you will be on the clinical station 1, another one on 2, and so on. One will be starting from the history station, one be from communication, and so on, as a circle. They will give you a sheet on your mark sheets, and that sheet will give you your own circle. It will tell you where will you start. Some people will be station number 1 for them is a development, and then they will go next to the history, communication, video, and clinicals. Is that all rule? I would say not. Some centers don't have that lovely, like organized circuit. So some centers will be random. You will start from clinical station 2, you will go to the videos, and then you'll go back to the clinical station, and then you go to the communication, and then you go back to development and history. So it might be a little bit not as smooth as the circuit. However, you will have your circuit known in advance by at least 1 hour before you start your exam. So you have to chill and relax. You just need to know where am I starting and where I will be going, and that's it. Yeah. My own experience for this exam, I would say it was a very fast day. You will never know it will finish faster than you think. I will advise you that you need to really sleep very well for that day, especially if you are on afternoon session. Sleep well in the morning. Don't wake up very early. What's the point of waking up early at 7 or 8? Maybe sleep until 11. Because if you wake up very early for the day, by 4:30 p.m., while you are still in the middle of stations, you will look tired and exhausted. So sleep well. Try to eat something just before the station. I arrived myself 1 hour and a half to the center before the exam, just to relax and not be in a rush to be late. Secondly, those 30 minutes, I have my coffee, I eat a little bit of dates. So I will advise eat something not heavy, but it has a little bit of good calories so you can survive the day. This day is all about your attitude. So have a good attitude. Believe in yourself. Believe that you are a physician and these are your patients. It's another day of the exam. So just smile, be happy, interact with the patients. They are there for you and you are there for them. So chill and relax. Attitude is very important, and keep the smile. Um, the other trick is that even if you don't know something, don't panic. Just go systematic. Because in real life, we do not diagnose a child from the first encounter and we look like, oh, wow, oops, yes, he has this diagnosis. This never happens in real life. What happens is that you take a history, you do the examination, you have an impression and differential, you do some investigation, you do some imaging, you discuss with tertiary center, all this to reach the diagnosis. So the examiner does not expect you all the time to say, okay, this is this diagnosis. But what they expect from you is that if you are the registrar on the floor, can I trust you to go systematically and convey to me what you are finding so that we can make a plan? That's what they're trying to see from you. So go systematic even if you don't know what's going on. The other fact of this exam is that it can go either way. You can pass, you cannot pass, and it might be a tricky day. You never know how it goes. So just go with the attitude, accept the outcome, whatever it is. So when you go to the exam, you don't panic. You are just accepting whatever gonna happen. If I pass, great. If I not, still great. It's an experience. I'm not gonna die after it. I'm fine. So accept it. This will make you chill on the day. My own experience that I actually passed from the second trial, and passed with a very nice score, 93%. I'm gonna show to you. But that was from the second trial. The first trial, I did not pass by only 1 mark. And I will not lie, for a day after the score was released, I was a little bit sad. But then I got the mindset is like, it's okay. It was a good experience. I learned from it, and let's go. And I was really surprised from the second trial. I got 93%. I lost only 5 marks out of the total. So what I would say is that this exam does not really reflect how good as a physician you are. Okay, because between my first trial and the second trial, I did not change a lot as a physician, just to let you know. But I changed my view of the exam and how can I approach the exam. So don't take it as a like clear definition if you are a good physician or not. I know a lot of great physicians and even great consultants who have took this exam even more than 3 to 4 times. So chill, take it easy, and accept it. So these are my scores. As I mentioned, the maximum score for this exam is 82. The pass mark usually change from exam to exam. Currently, the pass mark is 62. And with God blessing, I got a mark of 77. So this is almost 93% of the total. So what are the marks? The marks will be divided to you by the domains and what you achieved, and it will be marked by the station. I don't really find the domains is really reflective of how you should actually prepare for this exam. So I will go with what really matters is your performance for the stations. So in my performance, because I'm going to tell you about my technique, how did I get that score? And I also share the notes, my own personal notes with you. And I want you to know where am I coming from. So that's why I'm sharing this with you, so you can rely or trust the resources and the techniques I'm telling you. So for my clinicals, I got full marks in 2 stations, and then I lost 2 marks in other 2 stations. The other non-clinical stations, I got full mark on the development, I got full mark on the history in both communication, and I lost only 1 mark on the video. So in total, I lost 5 marks. This is very important for you to analyze how you should succeed in the exam. So I lost 5 marks. Where did I lose them? 4 out of 5, I lost them on the clinicals, and only 1 I lost on one of the videos. So the bulk of my mark loss was on the clinicals. And this will take me to the success strategy for this exam. To succeed, you have to really have a good preparation for this exam. And I will advise 1.5 months to 2 months if you feel ready. If not, 2 to 3 months. Okay, you have to have a practice group. You have to practice a lot, practice online, practice with yourself. We're going to talk more about this. And you have to develop your own style so that you will look comfortable on the exam day. The examiner needs to see a registrar on the floor, not a hesitant, unsure doctor. The other stress success strategy, I got it from one of the consultants, and it's one of the best advice I have ever got for this exam, which is you have to attempt to get a full mark in all of the non-clinical station, because you can never trust the clinical station. Pediatrics as a field is big, and you can never study everything for the clinical exam, and anything can come on the clinical station. So it might be tricky, and you might lose mark, and you never know which way it will go. So to really succeed this exam, you have to secure as much as you can full mark in all of non-the clinical station, and study as much as you can for the clinical, but accept that you probably most of the bulk of your marks that you will lose will be on the clinical. The other thing we talked about is the exam attitude. It's very important, your attitude. The examiner wants to see a confident doctor. Most of the times, the examiner is trying to see if you can work independent, because the consultants usually will not be on the floor with you on night shift and sometimes out of hours, and you will talk to the consultants over the phone. Can they trust you over the phone when you talk to them? So they are trying to see that in the clinical setting and the exam setting. Can I trust you when you call me, when you give me like your ISPAR handover, when you give me your impression? Can I trust you? So I need you to get the attitude of what, so what? It's another day on the hospital. I'm here to help my patients and just like discuss with my consultant. Get that attitude in you. You are a doctor. The other success strategy is try to get 10 seconds after every station you finish, just to offload from that station, forget it, and start to get back to the baseline, and prepare for the next station. Never, ever, ever read the station scenario without offloading the one you just left. Those 10 seconds is the key for you actually succeeding the next station. And you will hear a lot of stories, people saying, I didn't do well on this station and it really ruined the rest of the exam because I was really down, so everything went wrong. I'm saying, don't do that to yourself. Just get out of the room of the station, sit down, have 10 seconds, relax, and then open the station. In the clinical station previously, usually you get a scenario outside the station and they tell you this is the name of the child, their age, and please perform neurological examination, cardiovascular examination. So you prepare on the 3 to 4 minutes before the station to go to the station and do it. But now, and that was surprising in the exam I went to in February, that there are no scenarios. And on the 3 to 4 minutes, you sit down in front of the station, and usually this is a standard, just to let you know, between every station there are 3 to 4 minutes to prepare for the station. On the clinical station though, you will not have any scenario. You will sit down, just looking around, chilling before you enter the station, and then when you enter the station you will get the scenario. So how can I use that time? I would say use that time to really offload everything went out. Secondly, use the rule of elimination, which is I actually like got that in my mind when I was the exam. I was like, what should I prepare in my mind for this station? I have no scenario. And I figured out, okay, let me do elimination. So in my previous station, it was cardio. So what's left? So it's either resp, it's either abdomen, it's either neuro, or it's MSK. Okay, so if it is that or that or that, this is how am I gonna think about it? So rule of elimination helped me. So after the second station, it's like, okay, so now I have cardio and I have neuro. So what's left is one and blah, 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 and so on. So it will help you to use the time effectively and chill. The other thing is drink water on the exam. It's a long 4 hours, and you will be talking a lot for more than 2 hours. So drink because you will get dry. Yeah. So what are the resources for this exam? I would say you really need to go through the RCPCH face-to-face guidance hub. This is critical. You have to read through it because they will talk to you about the face-to-face exam with patients. And if you are still in one of the countries which have no patient, this is also the resource for you. And in there, you will find a lot of resources, videos, teachings, and documents. You really need to read those and download them, print them, use them, just like navigate through. The other thing and the other great website, which I would say the best website ever to prepare for the MRCPCH, is the London School of Pediatrics website, the MRCPCH Clinical Revision website. It's excellent. It have everything. How can you prepare for the exam? What is the exam about, the courses, and I'm going to talk about that later. And then it's talking about the books you can use, everything else. I mean, like even photos for them, and station wise. So they have like abdomen, cardio, everything is here. You can see even communication. And the great part is that they have videos. So you can actually see how you should perform on the clinical station, what to expect on the clinical station, and what are the performance you're expected to deliver, and the summarization after your examination. They also have communication guides and even videos. So go through this website. It's excellent website. This is how can I describe it? Excellent, pure perfection. And then what about the books? So these are the website, great, but there is a book that I can read. There's a lot of books. The best is the past test, and I'm going to show you the cover for those books so you can search for them. The past test is a great book. The MRCPCH Clinical Examination Practical Guide for Dr. Abraam Hanna, and I have contacted him, and he thankfully gave us the permission to use the book. He is providing it out of a charge. So check below my video. I'm gonna put a link into the drive where I will put all the resources I have that you can use, including Dr. Abraam Hanna book. And then the book called The Circuits. And this book, you will use it to practice with your friends and colleagues. Another book called Communication Scenarios for the MRCPCH. I personally did not use it, but a lot of people are saying excellent stuff about it, so it will be beneficial to have it. I didn't use it myself, and I got 8 out of 8 full marks on it. But it's a great book. You can use it, and I'm going to tell you about my techniques, how I did that. And then I have my own notes, which I'm going to share with you, and I hope it will help you out. Then you can think about, okay, I might attend a course. Yes, of course. So there are some free courses, and the Rebel course is one of the best, I would say. It's a free course. It's run by Pediatric Turini here in London. Um, I think they have a little bit of criteria for you to look to be part. Not sure if that's the full criteria, but I believe that they want you to say where do you work, which hospital you are in the UK, and what is your level of training, or if you are not on training, are you an SHO or registrar or what it is. Usually they practice with self-come, like first come, first served. So keep on the look, because they keep advertising when they will run their courses, and usually they run them before every exam, so 3 times a year. I would say you should also always get a small group to study together, and try to get a multi-diverse team together. So if you are working in the UK, try to make the team like multi-diverse. Make sure some of the team is international, some of the team is UK graduates, because you need to know how things work in the NHS, especially if you haven't been here for a long time and you will take the exam in the UK. You are expected to understand how the system works, and the language used in the UK is different from other healthcare systems. I'm personally from Egypt, and I can tell how we speak to the patients, the cultural differences. It really make a difference in how you'll approach patients, and how you should talk to the patients, and how the NHS system work. So just get groups diverse enough so that you will really learn the NHS language. There are a lot of courses which are paid, and they are all mentioned here on the London School of Pediatrics, Evelina course, London School of Pediatrics itself, Newham, Royal London Hospital, Gosh, Chelsea, Ealing Broadway. Just like if you want to attend, take one of those. I'm gonna say some of them are very, very expensive, and some of them are not as expensive. Some of them go up to 2,000 sterling pounds in cost, and others are less. My advice will be you can practice everything online. You just need the patient part of the exam. So if there is a course that you can attend, which will give you a little bit of a clinical touch of how the clinical station will be, go for that one. And it's not a necessary even. If you and your colleagues are working in a hospital and you can practice together, that's it. You don't even need to go for a paid course. Okay. So these are the books I used. These are covers for them: the past test, the communication, Dr. Abraam book, the circuits, and the website. So what is my study plan? The study plan, as I mentioned, timeline 2 to 3 months, but you need really to target 2 weeks off before your exam, because you really need to get into the exam mode. So try to take your annual leave, try to take a study leave, swap with your colleagues, but really try to get 2 solid weeks off. They might not be back-to-back weeks, but at least a full week before the exam off is very important. I would say I did read the past test, and I print, because I have the soft copy of the book, I printed the important pages from it, and I printed Dr. Abraam book, and then I used the London School of Pediatrics website I told you about. I watched all the videos, and then I created my own notes to build my own style. And I'm going to share with you. And my style was, before every station, I have to have only one page in my mind so that I get into that station and not be distracted. So focused into that station. So it's the mindset of one page. I'm going to share with you those pages. And then the practice. I practice with myself. I practice all the station with myself. I was recording myself on my phone. I was timing myself, which is very important. Don't ever practice without timing. And then I practice with colleagues on the Rebel course, timed also, and with colleagues online from some groups. And then what I did before the second trial is that I emailed the consultants on my trust and see who is free. I got some verbal advice from some consultants about the exam and how to approach it, and some consultants gave me the chance actually to practice with them in some like word rounds. So I did the examination, and then they gave me feedback of what they think I did right and how can I improve. So I did two sessions with consultants, and it was really, really valuable. So try to do that. And if you want to attend a course, attend. I attended a course which didn't cost a lot, and it was only for clinicals. They tried to give like a lecture or two, but it was mainly for the patients, and it was really, really valuable for me, because unfortunately none of the trust colleagues were taking the exam, so I was alone, and I couldn't get anyone really enthusiastic enough to practice with me away from the consultants. So that's it. If you want to take a break now, go ahead, because we're gonna hit after this on the stations. What I would say is that you can pause the video or just continue with me. So the general rules for the stations is that you have to get, as I mentioned before, the 10 seconds to settle and offload after every station. And after you offload, then don't read the scenario. You know now you are going for the communication station or history or whatever. Get to the mindset page and write it down. You will have plenty of blank pages. Write down your mindset page. On that mindset page, write down the patient name, because you don't want to go into the station and forget what was the patient name. And then some people get mental block when they go to the station. They don't know what to say, what should they say, how they should behave. So you have 4 minutes before the station. Try to get into the mindset. When I go in, I will say, hello, hi, is this is the mom, or this is the name of the child. My name is blah, blah, blah. And practice that so that will become natural and fluent. And you do this in real life in the practice. But sometimes in exam settings, you get mental block because of the stress. So try to practice it to get naturally with it. Try to relax, because you will relax everyone around you. The examiner will be relaxed and the role player will be relaxed. Try to play with the patients, smile to them, play with the kids. I was playing with a lot of the children, the clinicals, and everywhere. Okay, you have this lovely dinosaur. Oh, this is a lovely dinosaur. What's the name of this dinosaur? She told me it's the blue dinosaur. I was like, oh, bluey dinosaur. That's beautiful dinosaur. So just play and make children at ease with you. Try to be natural. If there is something bad or something difficult to share or something striking to share, be natural, be empathetic, show your human side, and don't be so stressed that you cannot show your human side. And let's crack on it. So first station, my favorite, the communication station. I got full mark on this one, and I'm going to share you how I did it. So the communication station is one of the short station. It's 9 minutes. And on this station, you just will communicate with the role player. The examiner will not speak on the station. Once you enter the room, you will give them the mark sheet for that station, and voila, you're gonna have 9 minutes talking with the role player. The examiner will not interrupt you. They will not say anything, and that's it. And that's the end of the station. So, what is the station about? I have these notes. You don't have to worry about the content on them, because I'm going to share them below the video. You can download them, you can print them, you can use them. So you don't have to write down after me. But yeah, I'm just going to highlight the important things. But then later on your own time, you can go and read through them to learn more. Communication will hit on few domains. It will be probably information giving, breaking bad news, giving consent, talking about a critical incident like an error or something, an ethical dilemma, or giving an education or teaching for a medical student or one of the juniors. And I just want to share with you this part, which is like, what is the format of the communication station? There will always be an introduction part. You go in, hello, this is blah, blah, blah. Nice to meet you. My name is Asma, and I'm here to talk to you about your child or the plan for your child or blah, blah, blah. And then, if you think you're going to break bad news or you want to like something important, you can tell her, before we go ahead, is there anyone else with you here today that you would like them to be present on this discussion? Or would you like us to call someone for you, especially if the news is impacting? So you can say, I'm here to talk to you about Sarah's blood results. And I'm afraid it's a little bit of news that we're going to have a lot of discussions about it. Would you like anyone to be with you here before we go ahead? And if there is anyone around that you would like them to be here. So set the tone. Speak in a way that they will be aware big things are coming up. They might need support or help. So set the tone. And then the rule is don't jump into saying stuff. Check what they know first. Because they might know everything you're going to say and they are just wasting time. So ask them, can I check or can I confirm with you? What have you been told so far? And then listen. And then, okay, I understand you might have a lot of questions for me now, but is there anything specific you would like to know in today's discussion? Let them tell you what they want to know, and then set an agenda. Okay, thank you so much for telling me that. So what we're gonna do on this talk today or this meeting today, I'm gonna tell you about the blood results for your child. I'm gonna answer your questions. Probably if you have further questions, we'll talk about them. I'm then going to provide you with some information, leaflets to read more, and we will arrange another meeting later. So that's the agenda. And then go ahead and share information. After you share the information, try rapidly to summarize. So in summary, what we talked about is one blah, 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 short and sweet. Was that clear? Would you like to ask me any further questions? So summary, check understanding. Do you have any more questions? I'm gonna offer you a pamphlet now to read more about the condition, and we're gonna plan to meet you again to answer any of your questions and follow up and talk about safety net. What I would like you to watch out at home is 1, 2, 3, and they are already on the pamphlet. Okay, so this is the communication in a nutshell. What about my mindset page? So this is my mindset page. While I'm sitting outside, after I leave the previous station, I know I'm going to communication station. I will sit down for 10 seconds, offload, and then I will get the blank paper and draw this diagram. It's not a lot, it's only few letters, but I know they are summary for something, they are abbreviation for something, but it put me into the zone of communication. Let me tell you what is this. So let's decode that diagram. The diagram is, I read the name, the age, and where am I, clinic or ward or whatever. What is the task? I'm just like to remind myself, I don't really write the task down, and what's relevant in the history. And then AWA, I need to make sure, check with them what they already know, want to know, set an agenda, okay? And then the SUQ, which is summarize to them, check understanding, questions. And then the other part, I'm sorry, it's behind this lovely yellow page, is SRS. The S is safety net, resources, which is the pamphlets, and the other is see you again. So safety net, resources, and see you again. And then the agenda will depend on the case. And every case will have a specific or a special agenda. Safeguarding case, this is the agenda. You need to give the information to the parent, pause, ask for an explanation of the problem, like why the child has a broken leg, and tell them how you medically will manage, and then have the safeguarding talk and the social services involvement. Other case, special case like ethics, you have to discuss arguments for and against. The ethical principles need to be covered, the autonomy, beneficence, non-maleficence, and justice. And Gillick competence and Fraser sometimes might come up. Teaching, you have to offer the person you taught some resources to read after your teaching, so don't forget that. In a procedure, how can you approach a procedure? You have to discuss the indication of it, the technique of it, the complication, and the alternatives for it. I put these two lovely sticky notes because they are things you need to know mostly. How can you give a teaching about the importance of a chaperone on the exam? And if a family is refusing vitamin K, how can you communicate? So this is in a nutshell, the communication decoding page. So let's go back to the mindset. So this is my page. Why did I put it? Task, relevant. I don't try these things, but I put it to remind myself when I'm reading the scenario, I need to focus on the relevant stuff on the scenario. Already know, want to know, agenda. And then I set the agenda here if something is special on the agenda. Do I need to draw a diagram to teach them something? If the diagram is beneficial, I do it. If not, I don't. And then the SUQ, summarize, understanding, questions, safety net, resources, and see you again. And that's it. We're done with the communication. Next is the history station. History station is a long station, as mentioned before. It's 22 minutes. 13 minutes will be a history time with a role player, which might be an adolescent or might be a parent or a carer. And then you will have 9 minutes with the examiner for discussions. So you can have a lovely read. I'm not going to take time for this because we're trying to make the video concise. But what I'm trying to say is that you will spend a lot of time taking history. The examiner was there, so you don't have to repeat the history again to the examiner in the discussion time. All what you need to do is to summarize concisely in 1 minute, maximum 2 minutes. How can you do that? Use the SPAR, okay? The situation, which means the problems, the relevant background history, and the impression, and what you're going to do. What you're going to do. And usually, what you're going to do in all the stations on this exam, you should organize them to be history taking, examination, okay, investigation. And on investigation, it has to be bedside testing, bloods, imaging, and then you go about treatment wise. And treatment will include you discussing with consultant the MDT approach, medical treatment, and surgical. So you have to be systematic. That's what the examiner is trying to get from you. So this is my history mindset page. So if I know I'm going to a history station, I write this down. And we're gonna decode together this paper. So let's decode it. Sorry, I didn't get time to remake my notes. So the whole idea is, if you go back here, this is your current illness discussion or current presentation. You analyze the current presentation, and then you analyze the relevant system, and then you go to, if the illness is chronic, there are some questions you need to ask for chronic illnesses. Some scenarios or some presentation have special questions you need to ask about. And then we have a Sawadi mnemonic I'm going to talk about. And you have the past medical history here and the management. So let's go for the present complaint, which is this part. So the present complaint, I analyze the present complaint as usual, and then the relevant systems, I make the mnemonic fever, burn, fever, burn, which makes sense. Fever burns everyone. So fever burns. So fever, F is for fever, and I put I next to it to remind myself about recent illness or sick or ill contact. B is the burn word. B is for breathing and bowel. Breathing and bowel. And in the bowel, I remember the GIT diagram, which is swallow, vomit, reflux, abdominal pain, diarrhea, stool, everything on that B. U is urinary. How is your urinary habit? And rash, and then N for the burn. And the N, I remind myself, it's the NGT or the NJT, which is neuro, joint, and trauma. And the T plus the trauma travel. It's important because many conditions will be impacted by the travel history. Then you have the mnemonic Sawadi. Sawadi is my own mnemonic, which I created, which is sleep. Is the complaint is impacting the child's sleep. It's very important in many scenarios like headache and asthma. What about their weight? Any recent weight change, weight loss, weight gain? And then A is for activity level, how they are. Are they active as usual, lethargic? And then D is diet. Any change in the diet recently? And E is for exercise. HEADS. The HEADS mnemonic is for the social history of adolescence, and it stands for home, education, activities, drug, and S's. And the S's is sexual, um, what else? Self-harm, and social media. So you can search this more online to learn about the HIDS assessment. And then you have the chronic illness. We're going to talk about it later. And then this mnemonic, I made it the P GAM I FOS. Just feel free to make your own mnemonic. My P GAM I FOS is P is for past medical, including the birth, all admissions, all surgery. G is for growth and development. A is for allergy. M medication. I immunization. FOS is for family history. And then O is for if the occupation of the parents is relevant. And obstetric, which means like if it's a girl, you need to remember about puberty and the periods. And then S is for social, and S other is for school performance. So this is in a nutshell what you should cover. Now let's go back to the mindset. So I draw this, And I was, okay, let's analyze the current complaint. When did it start? How long it was there? Blah, blah, blah. Things make it better, things make it worse. And then fever, burn, fever, illness, bowel, breathing, urinary, rash, neuro, joint, trauma, travel. And then if it was a chronic illness, we're going to talk about the question on the next few pages. Special, I'm going to show you another few slides of the special questions. And then the sawadi, the sleep, weight, activity, diet and exercise. And then if it's adolescent, don't forget the heads assessment, and then the PGAM IFOS. And then I do this part here. So after I read the scenario, before I go to the station, I will get into the mindset. If he asked me what you're going to do, I'm going to do the examination, investigation, treatment, SRS, exactly like the communication, which is safety net, resources, and see you again. The follow-up plan, basically. What I write down, I try always to get 2 to 3 differentials before I go into the station. And of course, when you take the history, your differential will completely change. But still, it's important to get a little bit of an idea. When you read the scenario outside, what might be my differential? Write it down. Also, you might write down a little bit of the investigation you might order for that. This will help you in the station not to really lose your focus, okay? So let's talk about the special. You remember here, we wrote the word special. So some presentation and some conditions have specific questions away from this diagram or this mindset that you really need to ask. So let's see those special. There are 2 pages. I compiled everything you need. So if you study these 2 pages, just go to the history relaxed. So in a chronic situation, chronic case, basically, a case that has a follow-up, you need to know these parts. When it was diagnosed, the regular follow-up with whom, last visit, what are the medication, growth charts, and everything. You can read that later. I'm not going to go through all of them, but I'm showing you. I wrote also the different MDT team that will be involved of the care of the child. So have a read. And then every case has its own unique questions. CF case has its own question, asthma, diabetes, food allergy, IPD, and so on. The other page is here. So these are the unique questions. What I might talk to you here now is the management, which, as I mentioned, is steady in all of the scenarios and all of the stations of any kind. Specifically for the history station, if the examiner asks you what you're going to do, how you will manage, you have to be systematic. I just took history. Next will be examination. Don't jump into invest. Don't say, oh, okay, I'm going to do these bloods. You haven't even examined the poor child. So tell them that you're going to examine the child. You're going to take a set of observation. You're going to put the child on the growth chart. And then if there is something special for that examination thing, make sure that you will do examination for that. For example, in diabetes, you're going to do the injection site. For example, for asthma, you're going to see how the child do the peak expiratory flow rate. And you can say also, I'm going to see the technique of how they give the inhaler. Then you can say about investigation. Some of the investigation will be bedside investigation. Some of them would be bloods. Some of them might be specific tests. Some of them might be imaging. Then the treatment. I'm going to check the compliance, the technique, give pamphlets, the MDT, and then don't forget you will discuss with your consultant at the clinic debrief. Okay, so this is basically the history station done beautiful. Now we're going to hit on the video station. One of the great station that you can get full mark easily, hopefully, if things are fine. So I would say there's not much for me to say on the video mindset station. But the mindset page is like this. You're gonna watch a video. You'll have 3 minutes to watch a video, and then it's a 9 minute station. It's a shorter station, so 3 minutes to watch the video and 6 minute discussion with the examiner. So in the 3 minutes, I want you to watch the video and write down the positives you are saying with the video. Okay, then try to say, okay, from what I have seen, what is the differential? Write down at least 3 differential. Yes, and then write down your plan, which will be what you're going to do. He will ask you what you're going to do for this. Always go systematic. This is just someone I saw. I'm going to take a history. I'm going to do full examination. And then I'm going to do those investigation and those treatment and so on. But remember, if it was an emergency situation, remember that you will say that I'm going to do a rapid A to E assessment. I'm going to give double two crash call. This is important first. And then I'm going to put the child on oxygen, get an IV access, and then go systematically. After we stabilize the child, we're going to go for a history examination, blah, 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 blah. Yes? So just have the situational awareness. And I'm trying to help you out. So I have a list of videos on my drive. This list of videos has been shared between us, the people who are taking the exam. I really don't know who created this list, but thankfully it was an open share, and bless whoever made it. So it's a very good list of videos which really mimic the exam videos you will have, which are short videos. Um, if there is voice, you will find voice. If there is no voice, there is no voice. The only drawback of this set of videos, there's a lot of videos. The only drawback I would say for this is that it doesn't have the answers. So you will have to depend on yourself in what is the differential, what do you think you and your colleague when you practice together. Well done. We're now cracking in the big monster, the development station. I'm saying big monster because it's the one of the long station. It's 22 minutes and it has the highest scores. It's 12 marks. So, and because we don't usually do it frequently on our usual practice, every day-to-day practice, we don't feel comfortable with it. So you have to spend time practicing for it. But thank God, Alhamdulillah, I have passed it with a full mark. So I will share with you how I did it. Let's go. It's a 22 minutes. You'll have a role player. Until now in the UK, there is no patient on the station, but I believe this will change. So keep an eye on the website to know if a patient will be there. So the 9 minutes will be the role player, the mother, or the role player. You will take a history from them, okay? And the history will include general history and a developmental history on the domains you will not assess. And then you will have 10 minutes to summarize the history in 1 minute, and in 9 minutes out of the 10 to conduct the developmental examination, which will be verbal at this point because there is no patient there. And then at the end, you'll have 3 minutes for discussion with the examiner. So let's navigate. So the 9 minute history with the role player. First of all, before you enter the exam station, you will have a scenario, okay, written with the name and the age. Sometimes you might have a picture of the child if they feel like it's relevant, sometimes not. And development station is covering the 4 domains of development. So you'll have the gross motor, the fine motor, the speech and language, and the social. So these are 4 domains. When the role player with you, you will go through the usual history, and in the usual history, you have to focus a little bit on the reasons which might impact the child development. That's why perinatal history is a key. You need to see if there was prematurity, if there was obstructed labor, if there was possible CP, all these kind of things. Family history of similar condition, and if the child has a developmental delay, does they have an educational and healthcare plan, the EHCP, in place or not? So don't forget to ask about that. And social history, of course, and also the MDT. These are unique things that you need to focus on the development station. You can read that later on detail. And then you still need to do a little bit of developmental history. Why that? Because the scenario will usually, you remember the 4 domains, the scenario will usually ask you to assess 1 or 2 domains. So you might define the scenario saying, please assess gross motor for this child, or assess gross and fine motor, or assess speech and social. That's it. So what about the other domains that were not asked for you to assess? These domains, you need to ask them in history. And this is the history you can ask about. So we call them the screening question because you're trying to screen for the other domains away from the domains you were asked to clinically assess. So basically, you are asked on those 10 minutes of the exam to actually tell the examiner how will you examine the child and decide their age from examination, not from history. But what about the other domains you're not asked to assess? These domains, you can ask about them in the history. And these are the screening question. You can read them later, but I will just focus in hearing and vision. Don't forget to ask about the hearing and vision. Ask the mother if she has any concerns with the hearing and vision of the child, and regress. Ask her if there is any skills that she believed the child had developed before and the child has lost, okay? And they are not able to do it anymore. Let's me show you the mindset page for my development station. So this is my mindset. If I know I'm going to the development station, I'm gonna draw this before even I read the scenario. And this is easy. This part is exactly as the history part, because you need to take that part of the history, the P, Gam, I, Phos, and on that part here, you need to focus on those lovely parts here, which is specifically for development. And then you have this part here, which is, I'm trying to, the name, age, and setting, of course, but then the onset, which is the current problem, why mom is concerned, and then ask if the child is in any pain, because this will be relevant for your examination, and ask her if he has been recovering from any recent illness, and then go through if he is being treated for anything, or if he is under multiple team, like, and what are the teams that he is being cared for, okay, and the teams he is following under. So these are things not to forget. But then this is the history bit that is specific and unique for the development. Don't forget the HVR. I call it HVR, not to forget: hearing, vision, and regress. Okay, and then I create this diagram for myself to ease my mind and get the focus again. So fine motor, gross motor, language, and social. And I write down the key elements, so that when I'm taking history from the examiner, I will write down next to the things what I think as age-wise. This is for you in the history. If, for example, the scenario was, please assess fine and gross motor, you are not allowed in history to ask about them, because you're going to assess them with the examiner. So when I read the scenario and it says, please assess like fine and gross motor, I do a rapid X on the top. So when I'm with the role player, I remember not to ask these will be with the examiner, but I will ask her about the language and social. So what are the prompts I'm putting for myself? In fine motor, you will assess how the child play with the cubes, how they draw, use the scissors, the beads, and use the book. In gross motor, how they walk, how they run, how they jump, use the ball and the stairs. And the language wise, how can they use nouns, verbs, preposition, negatives, understand comparatives, and understand complex language. In the social, I will do a lot of observation. We'll try to play together a game, the eating game, the doll game, and many of my assessment of social will be history from the family. Okay, that's it. So let's go for the magic paper, which is very loaded page, but it will save your life. That's it. Took me ages to create, but it's really comprehensive. So how can you approach a development station? I would say you need to do as every station: wash your hands, introduce yourself, expose the child, check if they are in pain, have a look around the room, and see if they are having any dysmorphic features, if they are welcomed. Ask what is the child doing at this point, go to their level and call their name, and then start your assessment. This is the assessment. I'm not going through it because we don't have time, but in a nutshell, cubes, as mentioned, cubes, drawing, scissors, beads, and book. And with everything, whatever the child is able to achieve, there is an age next to it. Like the gross is the same. And I'm gonna say a little bit about the language and speech. In language and speech, a lot of people lose marks because the resources we use does not really differentiate between receptive and expressive, and this is what the examiner wants to hear from you. Okay. So you have to tell the examiner first, I'm going to assess the receptive language, which means the child understand what you tell them. Okay, so under receptive, most of this is receptive. I'm going to see if they understand the noun. So I'm going to carry the ball in my hand and ask them, what is this? Sorry, where is the ball? Okay, sorry, you see, I get confused. So you're asking the child about the reception. So you will put a lot of toys and you ask the child, where's the car? Where's the ball? And then the child will pick it up, which means he understood you. So this is the receptive. The expressive, though, is if you carry something in your hand, like the ball, for example, and ask him, what is this? Now he will speak. So he will express himself. So you need to really differentiate between receptive and expressive and be clear with the examiner which is which. Most of the things here, everything here basically is receptive. The only few lines that are expressive are this line for the nouns and this line for the verb. So you can go through them. I'm going to show you now another slide for the expressive, other than these two lines. And then for the social, you have to observe a lot. And then there is a lot of history taking about their self-care, which is the bowel control, the bladder control, the feeding, are using fork, using knife, and all these kind of things. Because it's very intense. If I get time later, I might do like specific station videos, but for now I'm trying to give you an overall and share my resources with you. This is the page I told you about, which is the expressive language. So if the child is 2 years old, you can ask them, what is your name? And they should say their name. This is how they express. And they can say a sentence of 2 words. If they are 3 years old, they can tell you how old they are, and so on. So this is the way of them expressing. And you should tell the examiner now clearly, now I'm going to examine or assess the expressive language, and this is how I will do it. Okay? This is an excellent page, which I got from the London School of Pediatrics website that I shared with you earlier. And it has all the development also stages. And I love color coding, so you can see the color coding. Those written here is compiled on this page that I did. Um, um, and I did it in my own way because I felt it more easier for me that way. Here, I would say it's a great page, but be careful with the language part because it doesn't really differentiate between receptive and expressive, and you really need to say that for the examiner. Other than that, it's an excellent page. Get familiar with the toys that you will be provided on the development station, because for now we tell the examiner that I'm going to do this, I'm going to take that book, I'm going to show that. But in real life scenario, the examiner just might give you the box and tell you, okay, these are the toys, tell me how you will use them to assist the child. These are the cubes, I'm going to use the cubes and see how many cubes the child put together, and so on. And when the exam move into having a patient on it, you will really need to know how to use these toys. Get familiar with them. Perfect. Now, the last part of the development is about the discussion. So after you finish your examination assessment, now you will discuss. You have 3 minutes for discussion. What is the discussion about? The examiner will ask you, okay, tell me what you think from your assessment. You will tell the examiner, first, I would like to complete my examination. You just did one domain or two of the development. You didn't do proper examination yet. You need to do head-to-toe exam. You need to assess the other domains, because the other domains you took history, but you haven't really assessed it. You need to know if it's isolated developmental delay or it is global developmental delay. If you have more than one domain that the child has a delay on, this is a global developmental delay. So you need to know all of the other domains. Then don't forget the growth chart, plot their weight and height. Do neurological examination if relevant. And if the child came with a specific medical illness, attend to it. If the mother saying his ear was having a lot of secretions coming out or pus coming out, mention to the examiner that I'm going to examine the ear. I might refer for the ENT. Just don't forget that. And then you can say, based on my assessment, the child on the gross motor were able to do blah, 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 which means he was on the developmental age of this, on the fine motor of this, blah, blah, blah. So overall, the child developmental age is around, and then say it. Usually what they expect from you is that if the child is less than 2 years of age, not the developmental age, the actual age, they expect you, when you say the age, to be within like 2 to 4 months accepted. So, for example, the child is 2 years old and his developmental age is actually 8 months old. They allow you to say, they will accept anything you will say from 6 to 10 because it's an approximation basically, okay? And usually the ages that you will assess on development station should be for a child who is developmentally 5 years old and below. So the child real age might be 7, but the development age is 3 or 4. So don't panic when you find a child 7 years old on a development station. It tells you they are delayed somehow, and you need to know how far are they delayed. Okay, so this is what you should say, and then you need to discuss with the examiner what do you think is a differential, and what was the risk factor for this, and what are the investigation you will order. So I would say if it's a global developmental delay and it's unexplained, then you have to tell that you need to send genetics. take a TFT, do a metabolic screen, do some neuroimaging, do some bone profile for some condition, some bloods. Don't forget that you might have a hearing problem, so you need to do ENT and audiology referral. Visual impairment will need like ophthalmology referral. Motor impairment or problem will need neuro examination, probably neuro referral and some imaging. And if it was global, as I mentioned, some genetics. Okay, so this page has a lot of information. Please go ahead and read more later, but I'm just trying to tell you this page will have in it 75% of any discussion that you will have probably on the development station. So read it well, read it well. Now, for people who are tired, you can go for a break because now I'm gonna hit with the clinical station fast and quick, and then come back. Just pause it and come back. Next, clinical station. The tricky ones that people might lose a lot of marks on it. Let's talk about them. So, clinical stations are 4 stations. Every station is 9 minutes. You will have 6 minutes to do the examination and 3 minutes to discuss with the examiner. So you will always feel rushed on it. And sometimes the examiners will rush you out because not they are against you. No, they are for you. They are trying to rush you to cover all the domains they need to assess to actually give you the mark. So they're actually in your side. They are not against you. So don't feel bad if they rush you out. As I mentioned earlier, there is no scenario before the station, so you will get the scenario in the station. You can read more. I'm sharing most of my pages. You can have a read, but I will emphasize few things. The management part, which is here more neatly. Don't forget that when they ask you, what are you going to do? Or how you will manage them. You just did an exam for a small part of the child. So don't forget to say, first, I'm going to take a history. This is how systematic you should go. First, I'm going to take a history. Then I'm going to do full exam. I'm going to do head to toe exam. I'm going to take a set of ops. I'm going to plot the child on a growth chart. I'm going to put the child on a Turner staging for puberty if they are on adolescent. Okay. Then I'll do the investigation, as we mentioned, bedside, blood imaging, and then treatment. Be sensible. If it's a case require admission, say, I'm going to admit the child. If a child can be managed outpatient, mention you're going to manage outpatient. Then mention the medical or the surgical treatment, and then talk about the SRS exactly as the communication, which is the safety net, the resources, and the follow-up, which is CU again. Okay, and these are the teams that you will usually will need to mention on your clinicals. So let's start with the first. Before we go to the first station, the mindset of the clinical. Um, I had that before we knew that there was no scenarios. So I was creating this page that I will create and write down on it when I know that I'm going for a cardiac or neuro, but this is not the station anymore. So you will really not have this. I will say that on the 3 minutes time before the station, use it to get the rule of elimination and to really chill and offload your mental status from the previous station. Okay, so cardiovascular. You are doctors. I'm not going through everything on this because I don't want this video to be long. But as I said, my notes will be shared. I'm going to share what's really important on the slides, but other than that, we'll crack on. So in all of them, you will have to, when you enter the station, give the examiner the exam sheet and then do the wiper. And wiper is a mnemonic for wash your hand. You have to wash your hand. Get some gel on it. Introduce yourself. Okay, my name is Asma, one of the pediatric doctors here, and I'm here to examine Alex. Take permission. P is for permission. Is that okay? Talk to the child, talk to the parents, and then position the child if you need to. If you need the child to be flat on bed, you want them to be 45 degree, and then expose. Get the t-shirt out, okay? Get the trousers out if you need to have a look. And then at the end, you have to redress the child. Don't forget to plot the child on weight and height. This is on all the station. This is standard. Plot them in weight and height on the growth chart and have a look around the room. So talk to the examiner when you are doing things. Tell them, I'm just having a look around the room to see if you brought anything with you today that might help me out to know what's going on with you. And then have a look. If there is oxygen around, if they have a wheelchair around, if there are some medication on the table, have a look. And then this is a standard examination all the station. Have a general exam. Are they well, unwell, in distress, well grown, not grown, dysmorphic? Then have a look at the hands and neck, and then move ahead to the examination of the system. Okay, so that's a standard thing. I'm writing a lot here so that you can read and learn, but in real life, all this part might take 30 seconds to 1 minute max, and then you go through the other things. Okay, after you finish whatever, the time might not be in your side. So whatever is left, you have to tell the examiner. He will tell you, what do you think or what do you do? You will tell her, I will first complete my examination by doing blah, blah, blah. So every station is unique. Don't forget, what really matters in the cardiovascular exam is hepatomegaly for liver failure, checking the groin to check for the femoral pulse is very important, doing blood pressure check, and checking lower limb for edema. This is standard, okay? And then when you summarize, it will be a good idea to say that today I have examined Jack, a 3 years old child who looks well grown for his age, and I would like to plot his weight and height on a growth chart. Jack looks well. He is not showing any signs of respiratory distress, and he looks hemodynamically stable. There is no signs of heart failure. On examination, he doesn't have any characteristic facial features and no clubbing. However, on his chest examination, I was able to appreciate a soft systolic murmur of grade 2/6 on the left lower sternal edge with no radiation elsewhere, blah, 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 blah. And my impression is Jack has acyanotic congenital heart disease. That's it. Okay, this is how you present it. Okay, what you need to know for the cardiovascular station is the reasons for cyanotic heart disease, which is these, and you can think of them on numbers. So truncus arteriosus is number 1 because it's only one trunk. The TGA, transposition of great arteries, they are 2 arteries, so that's why it's number 2. And then tricuspid is 3. Tri is 3, so tricuspid atresia. The trigeal flow is tetralogy, which is 4. And then you have the total anomalous pulmonary venous return, which is 5 liters, so it's 5, and add to them pulmonary atresia. One of the colleagues said that on numbers, and I really liked it to remind myself. Okay. The other things that you need to know for the cardiovascular is the scars. It's very important to know the reason for right thoracotomy scar, left thoracotomy scar, and midline. You can read more from here, and the reasons for the murmurs. And when we present, we should say right upper sternal edge, left upper sternal edge, apex, left lower sternal edge. We don't say the word pulmonary area or aortic area, which is more unique to adults. Okay. So next is the respiratory station, similar to the cardiac, the same general things, and then the chest thing. Unique things for the chest is that to complete your examination, you need to do ENT exam, don't forget that, and do a lymph node exam, which is very important. The set of observation, including the oxygen saturation, and also doing the cardiovascular exam. It's part of the respiratory, okay? Next is your abdomen station. The same general rules apply. And then for the completion of your examination, don't forget that you need to do groin examination for the femoral check, of course, and also for any masses, lymph nodes, hernial orifices. And then also for the abdomen, it's about the anal and rectal exam to see if there's any anal fissures, any anal tags, any fistula, all these things. And bedside testing for it include a urine analysis, of course, and blood pressure. Okay, so what's unique for the abdominal station is that you need to know the causes of hepatomegaly, hepatosplenomegaly, and splenomegaly. And for myself to remember them, because I feel like sometimes you might get stuck, I divide them into infectious causes, hematological causes, oncological causes, metabolic causes, and others. And that's it, all of them the same. If you keep that in your mind, it will be easy to remember. So remind yourself and read them. Then you need to know what are the causes of renal mass. So if you get a palatable mass there, what's the reason? So have a read of the reasons for a renal mass. The other thing is about the abdominal scars. And this is the diagram of the scars that you need to know for the abdominal station. Really, really, really study them well. Open Google, check for photos of them, have real photos of them so that you can really appreciate, and when you see one of them on the exam, you really can speak about it. Okay, so I put them here for you guys so you can have a read and a look and read more about them. Okay, then it's the neuro, and the neuro is big and there's a lot of things to cover in neuro. So the first thing is the cranial nerves, of course. Just remember the general part on the neuro is exactly as the same as in your general examination. I wrote it down here for you so you can have a closer read. Same rules apply. Cranial nerves, I'm not going to teach you how to do it, but to remind yourself so that you will not get stuck mentally, it's easy to remember that it starts with the nose, the olfactory, then the eyes, which is 2, 3, 4, 6, and then it's the face, which is the trigeminal and the facial, and then go to the ear, which is the 8th, and then the pharynx, which is the 9 and 10, and then the shoulders, which is 11, and the tongue, which is 12. Then we always forget about hemianopia and the reasons for it, so I put a note for myself about it. And then you have the neurological peripheral examination, basically the peripheral neurological exam, including the motor and sensory and others. Be careful when the examiner asks you the question, because you don't have a scenario outside. You will enter the station, the examiner might tell you, please perform only motor peripheral examination on both upper and lower limbs. So this means only motor, don't go for others. If he asks you, do upper and lower motor peripheral neurological examination, it means everything. And usually the time will not be enough for this. So the question might be different. So just like listen carefully and talk to the examiner if you're unsure, okay? So the same rules apply, general examination, the same rule apply, and then you go to the uniqueness of upper and motor neuron lesion. I would say for the general check of the neurology, I love to use the dwarf mnemonic, DWARFS, dwarfs. So it's dysmorphism, and then wasting of the muscles, and then asymmetrical shape of the muscles, and then any rashes, and then any fasciculation, and skin scars. Okay, so that's it. And then you hit on the tone, power, reflexes, sensation, and coordination. And this is the power classification for you to remind you. Don't forget in the lower exam that it's very important to check the gait, and don't forget to check the back. Always remind yourself, when I ask the child to start to walk, before they walk, I will ask them to bend forward and have a look at the back and the spine. Okay? This page took a day for me to make. It's a very important page. I'll go through it a little bit with you, but it's a summary of all the neurological cases, so that when you enter the station, you can really navigate through where am I thinking, what's the differential, and all what I wrote here on blue and green is the summary of the things you need to know for the discussion, okay? So let's start. There are a few things that might trick you out, and you have to be careful. You might find some muscle wasting or muscle atrophy. Both look the same, so don't use them to say, oh, it's a wasted muscle. No, it might be just atrophied muscle, so don't make that your judge. Oh, it's upper motor neuron or lower. Both might have this. So just like wasting or atrophied muscle, both of them will have low power. You might in both of them have a child with wheelchair or not. You might have in both of them a child coming with machines or medication or suction machines or not. And as I mentioned, contracture disuse. So how can I really differentiate? So upper means higher. Up is high. So in upper motor neuron, everything is up. So high tone, high reflexes, which means positive colonus, high or upward plantar, which is Babinski positive, and spastic gait. The spastic gait, it depends on the lesion, if it's hemiplegic, diplegic. So diplegic will be scissor gait. We'll talk about this later, but scissors, or hemiplegic will be circumductive. And this is how you say, okay, this is upper motor neuron. Coordination sensation might be impacted and might be okay. So what are the reasons of an upper motor neuron lesion? You need these yellow parts as your differential. So you need to know what's the differential when you are asked for it. So this is the yellow part. Okay, upper motor neuron differential is CP, stroke, trauma, infections, tumors, or MS, multiple sclerosis. Okay. Okay. So what if I have nothing of those? I have low tone, I have low reflexes, I have the blunters going down because it's everything down. Lower is down in tone, down in reflexes or no reflexes, planters down. It means probably you are on the lower motor neuron lesion. Okay, sensation and coordination usually are normal, and I will tell you if they are not normal, what to think about. So lower motor neuron lesion, it might be something to go with the neurons, neuropathy, or with the musculopathy. Okay, so if you have a low tone, low reflexes, but coordination is okay, and sensation is fine, this category you go through here, and this will be This is your differential for it. Okay, this is your differential for it. So what's the differential? It might be a lesion in the anterior horn cells of the spinal cord. So it might be SMA, spinal muscle atrophy, poliomyelitis. It might be the nerve fiber problem. So it's Guillain-Barré syndrome or peroneal muscle atrophy. But I will talk a little bit about this because it's tricky. Or peroneal muscle atrophy, which has different other names. Charcot-Marie-Tooth disease or hereditary sensory and motor neuropathy. Or you have, this is neuropathy, yeah? Or you have musculopathy. And musculopathy will be Duchenne muscular dystrophy, Becker muscular dystrophy, myotonic dystrophy, and then other problems like polymyositis, thyroid, steroid overdose or iatrogenic toxicity, spina bifida, transverse myelitis. All these are differential for a lower motor neuron lesion, usually with preserved coordination and sensation. Excellent. What if I have a lower motor neuron lesion and then I found the coordination is impaired? So low coordination, you see the green part here. So it's a lower motor neuron and I have lost coordination. So I ask the coordination and it's completely lost. What should I do? This means you are probably either cerebellar ataxia or ataxia-telangiectasia. Okay? Again, so if you have lower motor neuron lesion and the coordination is lost or messed up, but the sensation is fine, their sensation is okay. When I check the sensation, they're fine. What is the differential? It will be cerebellar ataxia or ataxia-telangiectasia. Okay? And how will I know the sensation is okay? You will do sensation check, or when you do the gait check, when you do the Romberg test, it will be negative. They will be standing. When they close their eye, they will not fall. They will be swaying, but they will not fall. So they will not fall on Romberg, but they are ataxic on the gait and they have no coordination. Then think, okay, this is ataxia case, cerebellar ataxia or ataxia-telangiectasia. Okay, that's clear. But what if, which is tricky part, what if it's a lower motor neuron lesion? I have lost coordination. Okay, they are like messed up and ataxic and no coordination at all. But when I check the sensation, it's impaired. They have sensational problem. And when I did the Romborg test, it was positive. My God, what does this even mean? Everything is messed up. Lower motor neuron, low sensation, lost coordination. What is it? It is either one of those two. It's either Friedreich's ataxia or peroneal muscle atrophy. Simply how I think about it is that if I find the lower motor neuron lesion and I do the Romberg test, if the Romberg test is negative and they are not falling when they close their eyes, I completely think of cerebellar ataxia or ataxia-telangiectasia. If I do the lower motor neuron lesion, and then when I ask them to stand and close their eyes, and they'll fall when I ask them to do that, it means it is a positive Romberg test, and then I think about Friedreich's ataxia or peroneal muscle atrophy. Okay, so that's how you can navigate through. And a tricky part for Friedreich's ataxia, which is very unique for Friedreich's ataxia, is that Babinski sign, which is the plantar reflex, is actually positive, which might trick you because here you did everything, as we said, high tone, high reflexes, everything, and Babinski is positive upwards. So what is the only condition, which is a lower motor neuron lesion with a positive Babinski? It's Friedreich's ataxia. So how can I differentiate from upper motor? Oh my God, you have a lower motor neuron lesion, you have low tone, low reflexes, and you have ataxia, which you don't have usually most of the times on upper motor neuron. Okay, and then you can read about all the blue and green parts. It's extra knowledge. What's really important on this page also is your discussion part. For any neurological case, you'll have a discussion section. And the discussion, you need to talk about what you're going to do. And you will definitely have to take a history, focusing on perinatal history, history of any trauma, family history of a similar condition, and then investigation, which include bloods, imaging, CT, and MRI. And if it's a lower motor neuron lesion, you need to think about, am I going to do an EMG, a nerve study, a muscle biopsy, and the MDT team as usual. Okay, so this is one of the key pages. I hope it will help you out. The other thing on neuro is cerebellar examination, like the ataxia case. And this is how you perform the neurological cerebellar examination. So have a look. And this is the different gait: the hemiplegic, the cerebellar, the cerebral palsy diplegic, myopathic, and neuropathic. So have a read. And then the neurological examination for a child who is less than 1 year of life is a little bit tricky and unique. And that's why I created this page, to tell you how can you do a cranial nerve exam on an infant, and how can you do peripheral neurological examination in an infant. Okay, have a read. And then the musculoskeletal system, which is the PGALs, the pediatric gait, arms, legs, and spine examination. General exam as usual. But then when you go to the arms, the legs, the spine examination, you follow the rule of look, feel, and move in all of them. So don't forget that. And usually you have to also learn the Brighton score for the hypermobile syndromes. So this is a very lovely page. Just read through it to get through, and you can watch one of the YouTube videos about how to do the musculoskeletal exam. It's a very nice exam, so learn it. I was very keen to make some notes for the MSK, but unfortunately I didn't write much. But this is the main things that you will discuss on the discussion part of MSK clinical case, which is what are the investigation you would do, have a read, and if there is a joint unwell, what you would do, and what are the red flags. Mainly in any MSK case, you need to exclude cancer and sepsis, and these are the things you need to look for to exclude those bad stuff. I think I did now finish my clinicals. Woohoo! But I would say the general advice is, for the clinicals mainly, is study the cases that will come to the pediatric clinic for annual review, including neurofibromatosis, tuberous sclerosis, diabetes, cystic fibrosis. Really learn them very well. Always think of common things first before you go to uncommon and rare stuff. Revised syndromes, specifically the common ones, especially Down syndrome, you have to know it by heart. Practice eye examination, because most people will expect cranial nerve exam, but not eye exam. An eye exam, I remember that, plus general examination are looking around the child and seeing if they are dysmorphic and look and everything. And looking at the eye itself to see if there is lid retraction or ptosis, all these lovely things, and checking the pupils, checking the colors of the, this is all inspection. But then on the eye examination, you need to do the squint check, which is cover and cover test. And I use the mnemonic AFROC to remind myself I need to check for acuity, field, reflexes, ophthalmoscopy, and color vision. Okay. On the cardiac condition, when you are on the discussion part, don't forget to tell the examiner that you will talk to the parents about reducing the risk of infectious endocarditis by giving a good advice about dental hygiene, no piercing, and no tiptoeing strategy. And I would advise that we don't usually hear a lot of murmurs on the practice for specific like scenarios, unless you go to a cardiology clinic. So practice by listening to murmurs. And I really found an excellent playlist on YouTube, which have lovely audios, very unique for all the murmurs. I would really advise you to listen to it. It will teach you a lot. It's precise, 1 minute for each teaching. Excellent. Just like go through it to learn the murmurs. Don't forget when you mention about growth charts on the exam that there are some adapted, unique charts for specific scenario, like clinical presentation. So Down syndrome has its own growth chart. Turner syndrome has its own growth chart, and achondroplasia. These are the three conditions that I am aware of. There may be others, but I haven't gone through that. So please learn that and tell that to the examiner. I'm going to plot them on the special Down growth chart, okay? Then the MDT approach is about, if you forget the MDT, like what teams are, think of it on the 3 dimension: health, social, and education. So health will include all the like the teams, clinical teams, neurology, physiotherapy, pulmonology, whatever. And then social. So social services, support at home, support groups, and everything like that, including also psychological support. And then education. What about their school? Do we need to do an educational healthcare plan for them, and so on? And the clinical station, because you are only constricted to 9 minutes, you will be rushed out. And I will advise that you comment while you're examining. Be sensitive not to use a lot of clinical jargons, but you can really tell the examiner what you're doing by doing it and saying it. I was saying to the child, let's have a lovely look at your fingers. And then I do the clubbing sign. I have these lovely fingers. I have these, your hand is warm and nice. Something like that, you know. I'm listening to the heart. It's going to tell me all the secrets, you know, something like that. So just like try to talk while you are working because it will save you. And then you say, I'm checking your tummy. I'm seeing your lunch. I'm seeing a lot of organs inside. Oh, I cannot feel anything except the lunch. This is how you tell the examiner, I couldn't feel any organomegaly. So just talk to the examiner because this will save your time on summary because you cannot have time to summarize everything you did on the 6 minutes in 3 minutes and then have a discussion. I would say focus on your patients. It's very important to keep an eye on the child and the role player. If they are frustrated, if they are scratching themselves, if whatever they are doing, focus and ask them and talk to them about it. Okay, it might be a clue. Okay, so just like focus with them. In the video station, the advice will be try to take your time. In the video, there are a lot of things there that you need to be careful about. Have a look to know the setting. Is it a hospital? Is it a clinic? Is it ER? Is it at home recorded video? Then look at the child themselves, how they are. Are they dysmorphic? What they are doing? Are they sick? And then if there's anything attached to them, are they getting any medication? And then is there a monitor nearby? What are the numbers on the monitor? What is the oxygen saturation? What is the heart rate? Have a look so that you really get the whole picture. And then write down your differential 2 to 3 so that when you start the discussion with the examiner, you have something in mind to say. My final remarks. It was a long video. I would say always stay positive. It's a great experience. You are already a great physician that you reach this stage, and it's the last step of you finishing the real membership exam. You have been doing this for a while. You dealt with the children a lot, so be positive. Smile in the exam. You are the doctor. These are children, and most of them are patients. They need to see you comfortable. They need to see passion and happiness in you so they can feel optimistic about life. I would say always remember to take the 10 seconds after each station to offload and get the mindset paper ready with you and write it down even before you read the scenario to get focused into that station and take all distraction away. And then I would say, if you believe in God like me, I believe in Allah, then pray and put your worries in God's hands and forget about it. I really like you to forget about it and after you finish the exam, live your life. It's gonna take 5 to 6 weeks to come back. You cannot keep worrying. Just like forget about the exam, live your life, and hopefully with God blessing you will pass. So if you pass, please share with others, share the knowledge, spread the knowledge to everyone. It's a bless and it's a great thing that we all can help each other on this. I would say thank you so much for staying with me until now. If you have learned anything and you feel like this was helpful for you in any way, I would really appreciate if you give me feedback because I'm trying to improve myself and I'm trying to improve how I help other people. So this is a QR code which you can scan and go through my questionnaire. It's not taking more than 2 to 3 minutes. And this is the link if you need to click on the link. I'm going to put my presentation, my like PowerPoint presentation, also in the link below the video so that you can download it and you can have access to the links and everything within it. And also this link if you would like to give me a feedback. All the best, guys. Don't forget after the exam, have a lovely meal. It would be great if you have it with your family. Congratulate yourself for taking the exam, regardless of the outcome. And thank you so much. It was a pleasure having you, and take care. Bye bye.